Good evening, everyone. Thank you for being here tonight. My name is Savina Chacheva. I serve as the program director at the Cancer Wellness Center. I'm delighted to welcome you tonight for our lecture titled Pathways to Progress, Advances in Gynecologic Cancer Treatment. Before we dive into today's presentation, I would like to take a moment to share more about the Cancer Wellness Center and the free services that we offer. The center was founded in 1989 as a nonprofit organization with the mission to help anyone touched by cancer find a way forward. Each year, our free counseling services, support groups, and health and nutrition programs serve nearly 2,000 community members of all ages and backgrounds. People with cancer, family members, friends, and caregivers all come to us to connect and cope. Our services, which are both virtual and in person, include education programs like the one this evening that aim to help you navigate the varied challenges that come with living with a cancer diagnosis. Wellness classes like yoga, meditation, nutrition, and more that provide a holistic approach to healthy living. And support services, which include counseling for individuals, families, couples, children, and those bereaved, as well as support groups that are designed to help any of our participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and I'll put the link in the chat here for us too. Now, without further ado, I would like to welcome Dr. Vogel from Endeavor Health tonight, who will be presenting on this informative topic. Thank you, Dr. Vogel. Welcome.
Great. Thank you so much for that welcome. I'm going to try to share my screen. Here we go. Got it. This is not my technology is not my strong suit. So as those of you who know me know. So thanks for inviting me. I was really excited about the opportunity to speak. And I thought when asked what topic I was going to present, I thought I've got to do advances in gynecologic cancer treatment because we've just had so many groundbreaking things happen over the past couple years and so many treatment paradigms that have changed. So then I made my slides and there's 67. So then I panicked and I thought there's no way I can do this in an hour, which is actually a good problem to have because it means we have a lot of things to talk about. But that being said, I'm not going to fly through this. We're going to go through some things a little bit more slowly than others. I may skip over some things if I think we're not going to make it where I want to get to. And if that's the case, we talked ahead of time. And if I need to come back and do a part two or there are questions at the end that I can answer, I will. So we're going to not panic and go at our own pace. So I wanted to start off by reviewing some clinical trial endpoints, going over some definitions to give you an idea of how we as oncologists determine whether a treatment is effective or not. The goal is actually to go over some survival curves, to look at some trial data like it would be presented when we go to meetings, just so that my hope is you leave this with a context and a terminology to go back to your oncologist or and have an informed discussion. Or I never am advocating that you're Googling, but if you come across something on the internet and you see a survival curve or you see some raw data presented, it would be nice. I hope you'll have some context and be able to interpret it. In that context, I do want to review some recent clinical trials and the data with regards to endometrial, cervical, and ovarian cancers, all of our major cancers. I am going to touch on PARP inhibitor data because the indications have changed over the past several years, so I feel like I'd be remiss not to go over that a little bit, although I'm sure many of you are familiar with some of this data already. And then lastly, I really want to leave time to discuss some of our current clinical trials that are open at Endeavor and give you some contact information for how you would get in touch with us if you were interested in participating or interested in learning more about what we have to offer. So we'll begin at the beginning and talk a little bit about definitions and clinical trial endpoints and how we define treatment efficacy. So we talk a lot about progression-free and overall survival. These are the two biggest endpoints that we use to determine whether drugs are effective when we study them on clinical trial. There are other ways whereby we can measure the effectiveness of a therapy. Objective response rate is a way to objectively gauge how much smaller cancer gets with treatment. Clinical benefit rate is a way to determine who are the patients and how many that are going to benefit. And then duration of response is if something is working, if you do get a response, how long does it last? And all these are important measures and help us figure out what the best option for people is. I am definitely a visual learner, so I think some of these concepts are better illustrated than verbalized. And so here we have a cartoon looking at progression-free and overall survival. Progression-free survival is delineated here by this blue arrow, and it essentially stands for the length of time during at diagnosis or after treatment for cancer that someone lives with the disease, but it doesn't get worse. And so this may be a period of remission if the cancer is completely cleared with chemotherapy, or it may be a period of stability. This progression-free survival is a very popular endpoint for clinical trials. It's really easy to measure. It's something that we use CT scans for and sometimes tumor markers. And it's an outcome that's fairly common. So it's a nice way for us to compare one treatment to another. Overall survival is delineated here by this green arrow, and this is the length of time from either diagnosis or start of treatment that patients diagnosed with the disease are still alive. And this is also an important endpoint. Obviously, we want to improve survival. That's our main goal with most of our treatments, but it's a little bit of a muddier endpoint because there are many things that can impact survival that may not be cancer related, and overall survival is not going to look into the details of that. So complete response, partial response, and stable disease are quick and easy ways that we objectively can determine whether or not we think something's working. So for example, if you have a CT scan at the start of treatment and there are tumors that are visualized on the CT scan, and then you take a certain treatment and we repeat the CT scan and everything is gone, that's a complete response. And so that we would say denotes a very effective treatment. This does indicate a remission. Typically, it does not necessarily indicate cure, but it's an easy and reliable way for us to determine quickly if a treatment is working. Similarly, partial response is also indicative of an effective treatment. That may mean that you have, if there are several tumors, maybe they don't go away, maybe some of them or all of them get smaller, but again, we're seeing an improvement on scans. So again, we would say, hey, this treatment looks effective. Stable disease is also typically a measure of efficacy and something that is important. I talk to people about the fact that when we are not treating cancer and we're doing CT scans, we will commonly see the cancer grow, which makes sense. We're not treating it. So if we then treat and we don't see tumor growth, that's a good thing. So I definitely consider stable disease a win, as do most oncologists. So complete response, partial response, and stable disease are all indicators of an effective treatment typically. Progressive disease is cancer that's growing on therapy, and generally this would not be an effective therapy. So if this is the case, we're usually looking for next steps. Objective response rate is percentage of people in a study or treatment group who have either a partial response or a complete response to treatment. This is a very, very common measure of efficacy in clinical trials. You'll see it on a lot of the slides that I have upcoming. And it's especially in earlier phase clinical trials, it's a quick marker, and we get responses faster than looking at progression-free and overall survival, so we use it frequently. Clinical benefit rate includes patients with stable disease as well. So this is also an important marker of efficacy. So these are the number of patients or percentage who have either had a complete, partial response, or stable disease for a period of time. So they've all had some response. And I tend to, when we talk about clinical trials, we get excited as oncologists if we have an objective response rate of 30%. And I've talked to patients who say, or friends that say 30%, that's not very good. But what I like to remind people is that does not include, the objective response rate does not include the patients with stable disease. So when you add those in, the clinical benefit rate for most of the drugs, especially a lot of the newer ones, goes up to 80% or more. So the majority of patients who get the drugs actually do get some benefit. It's just that with the objective response rates, the people with stable disease fall out. So, and that's still an important measure of effectiveness. The duration of response is the length of time that we have stability or ongoing response, and that can be important too. So for the people who have a response, how long does it hold? Certainly we love these long durations of response that we see with our immunotherapies that can go on for years. That's certainly more meaningful than a duration of response of a couple months. So that's another important way to determine how well something is working. So this is the last of the definitions, and then we'll get on to the more interesting stuff, hopefully. But I wanted to just mention median, which is the way that we measure all of these endpoints: progression-free survival, overall survival, objective response, or excuse me, duration of response, et cetera. And it's a statistical term, and it simply is the middle value in a set of measurements. So it's the point at which 50% of the data falls above and 50% of the data falls below. And so, for example, with regards to median overall survival, it's the length of time from either the date of diagnosis or start of treatment that half of the patients diagnosed are still alive. It's the midpoint. And similarly, with median progression-free survival, it's the length of time from date of diagnosis or start of treatment that half of the patients are either cancer-free or have stable disease. And the way that I think about it is it's the number right in the middle. So if I get a median progression-free survival of 24 months, of 2 years, then that tells me, okay, that's the number right in the middle, which means there's a significant proportion of patients that have a longer progression-free survival. And then there are patients that have a shorter progression-free survival, but it gives you an idea of the group as a whole. It's a little bit more informative than mean and average in this setting. Okay, so we will move and talk a little bit more about clinical trials themselves. So I'm going to start with endometrial cancer because I think that probably of the three, endometrial, cervical, and ovarian cancer is the disease site in which we've seen the most progress, and we've really gotten good about targeting our treatment and figuring out what works best for whom. So this is a study that many of you, I'm sure, have heard of. It's the Ruby trial. It was a large trial that looked at patients with advanced and recurrent endometrial cancers and added an immunotherapy to the basic chemotherapy backbone to see whether or not we would get improvement in outcome. Essentially, the standard therapy for advanced and recurrent endometrial cancer for decades has been chemotherapy, specifically carboplatin and paclitaxel, which is what we use for most of our cancers. Despite that this had been the standard for years, the long-term outcomes were not as good as we would like, with a median overall survival of less than 3 years. So the investigators, the designers of the trial, wanted to add dostarlimab, an immunotherapy, a checkpoint inhibitor, to the chemo backbone to see if this might boost response. So a little bit about dostarlimab, and I have a cartoon on the next slide that's probably a little bit more illustrative. So it is an immunotherapy, a checkpoint inhibitor specifically, and it's a monoclonal antibody. Antibodies are naturally produced by our immune system. We can also engineer them in the lab and use them as mechanism for treatment. So monoclonal antibodies, and dostarlimab in particular, binds to a protein on the surface of immune cells. PD-1 is the name of the protein. It's a receptor. And the dostarlimab, the antibody, blocks the action of this receptor and essentially boosts the immune system's ability to kill cancer cells. And so here is a little bit of a better illustration. So at the top, this is a scenario in which you do not have dostarlimab on board. So this blue cell is an immune system cell, a T cell to be exact. And then you've got the PD-1 protein, which is a receptor that's sitting on the surface of the immune system cell, the T cell. The cancer cell is a pink cell, and that cell is able to connect with the immune system cell via this PD-1 receptor and is essentially able to block itself from view from the T cell. So in this instance, the T cell, your own immune system, doesn't see the cancer cell. So the cancer is able to live and proliferate right in concert with the immune system, and no action is taken against it. In contrast, if you give dostarlimab, it binds to the PD-1 receptor, and you can see it here, the little Y shape, the monoclonal antibody. When it's bound to the PD-1 receptor, the cancer cell is not able to bind to the receptor on the immune system cell. And so in this instance, the immune system can see the cancer and then can kill it. So the idea behind dostarlimab is that it will ramp up the immune system's ability to do its job and kill cancer cells. And this, in conjunction with chemotherapy, was thought to maybe improve the efficacy. So this is a slide that is busy, and which is what all the slides look like when we're reviewing clinical trials and conferences. And there are certain parts of it that I'll go over, and then we'll go over in a little bit more detail. So this is the Ruby trial that we've been talking about. So the eligible patients tend to be over here on the left. So this is going to describe the patients that the trial is studying. In the middle, these colored boxes are that this is the treatment schema. And then over here on the right, you'll see here are endpoints. And as we discussed previously, PFS, progression-free and overall survival, they're the primary endpoints. They're almost always going to be. But then you've also got objective response rate, duration of response, and DCR is the same as clinical benefit rate. So all these things that we talked about are going to come up over and over again. So these are stage 3 and 4 endometrial cancer patients in the primary setting and recurrent disease. One thing that we'll talk about a little bit more on the next slide is that this group wanted to highlight a specific molecular subtype in particular because the thought was that perhaps immunotherapy would be best for this subtype. So when they designed the trial, they said, hey, we're going to let all these endometrial cancer patients participate, but we want to specifically pull this deficient mismatch repair subgroup out so that we can analyze them separately because we bet that the treatment is going to work very well in this group. And so here are the treatment regimens. This is just your basic carboplatin paclitaxel chemotherapy. There were some placebo added in here because they wanted to blind the investigators and the patients to what they were getting, which is not done in all trials, but done in some. And then the purple boxes, these are the experimental regimens. So this was carbotaxol, the basic standard, but we added dostarlimab to the chemotherapy, and then dostarlimab was continued for several years as a single agent as maintenance, okay? So just taking a little bit of a step away for a sec to talk about molecular subtypes of endometrial cancer, which many of you are likely aware of. So we have gotten smarter and we now realize that you can essentially classify all endometrial cancers into 4 different molecular subtypes, and they all behave differently, and there are different treatments that to which these will preferentially respond better or worse depending on what the type is. So the mismatch repair deficient group, the MMRD group, which I alluded to earlier, is a group that in earlier clinical trials has shown to be exquisitely sensitive to the effect of immunotherapy. So again, for the Ruby trial that we're talking about, the investigators wanted to make sure that they evaluated the efficacy of the treatment specifically in this group because the thought was, these patients are probably going to benefit. We think this will be the case, and so we want to pull those out and look at those people separately. And so what did we show with the trial? Well, the dostarlimab was helpful, and we did see a significant overall survival benefit. So now I just want to review the survival curve and how we interpret it with you. This is what all of them look like. And so this is just a basic 101 on survival curves and what they look like. So if you go over here to the left corner at the top where it says 100%, this is when all of the patients are enrolled and the trial began. Sorry. And so everybody has been enrolled, everybody started treatment at this point, everybody's still contributing to the curve. And if you go down here in the left corner, this is the time point, time 0, that starts the trial. As patients participate, the cancer in some patients will recur and people will no longer be part of the study. So they will no longer contribute to the curve. So you will actually see the probability of patients participating, the probability of survival going down. You can see here the red line is the placebo line. So it's carbotaxol, it's not placebo. This is the standard therapy. The purple line at the top is the group that got the dostarlimab. You can see that these curves separate. And so this tells us that you have more people that are contributing to the dostarlimab curve because the drug is working, right? So you're having fewer events. There are more people that are staying on study, or there are more people that are alive without disease in the top group compared to the bottom group. And what indicates a really good clinical trial or a really good outcome is when these curves remain separate, okay? So even down as you have fewer people participating, there's still a difference. There's a space between these curves. And so this, when you see survival curves like this that remain separate, they don't come back together, that usually denotes that you've got an effective therapy, okay? So this was amazing when they looked at the deficient mismatch repair patients specifically in a category by themselves. The difference was amazing. So there were many fewer patients on the dostarlimab group that had disease recurrence or death, and this is evident by the difference between these curves. Another way that we evaluate this is we actually look at the median overall survival, which, as we described earlier, is just the number at which half of the patients in the group are alive. And in the dostarlimab group, which is the purple, is written in purple here, you got an NE. Well, what does that mean? Well, that means not estimable. And the reason that it's not estimable is because at the time of evaluation, at the time of analysis, almost everyone in the dostarlimab group was still alive. They were doing well. So they couldn't even calculate a median for the overall survival. So these are exactly the type of curves that we like to see. These results we get really excited about because it tells us, hey, this treatment is really impacting people's lives and improving their lives. So this is the perfect survival curve and is what we're looking for. So then the next question is, well, does this treatment work for everybody? And the answer is probably not equally for everybody. And the authors, or the investigators of the trial went about to evaluate that further. So these are also survival curves from Ruby. It's just these are progression-free instead of overall survival. And they're similar to the ones that I just showed. And again, here's the deficient mismatch repair group, and there's a big difference. But then when they look at the overall population, there's also a difference. So again, the progression-free survival was good, as was the overall survival. Now, the problem when you are looking at a trial like this, in which you have a group that you know is really going to benefit, is that if this group, these deficient mismatch repair patients, are part of the overall group, when you get an improvement in the overall group, does that mean that the treatment is actually working for everybody? Or does it mean that you're just seeing an improvement in the overall group because the impact in the group that benefits is so high, it drives these results? So one way to try to get around that is to actually look at the patients who are not deficient mismatch repair separately to see whether or not there is a benefit in that group as well. And so this is what they did. And this was, again, was the Ruby study. This is what they did in this analysis. They pulled out the proficient mismatch repair patients, who's everybody else, not the deficient mismatch repair. And they said, okay, did these people benefit by the addition of the immunotherapy dostarlimab? And essentially they did. And so the progression-free and overall survival are not as, the magnitude of benefit is definitely not as great, but it still looks statistically better. One brief comment, because this can be very confusing with looking at survival curves, is I just talked about how you don't want the curves to cross. If the curves cross, it's no good. It means that one treatment is not better than the other. And if you look over here at this progression-free survival curve, you do have the blue line, which is the dostarlimab line, that looks like it's dropping down and crossing over the red line, which is the standard chemo line. This, however, is not indicative of the curves crossing. This is confusing and happens graphically when they plot the data. What this means is that at this point in time, there are patients that you don't have follow-up on. And so what the program does is it only includes those patients up to the point of last contact. And because there are contacts for other patients that extend beyond that point, what you end up getting is just this straight line down, which means that there are patients that are censored on the curve for which you don't have full information. And so that can look confusing, and it may look like the curves cross, but they don't. And that's you'll notice that with some of the other survival curves. So it's just something that you have to be careful. You have to pay attention. And then this is the investigators' attempt on Ruby to say, okay, we looked at the deficient mismatch repair. We looked at the proficient mismatch repair. We're going to look at the 4 specific molecular subtypes more closely to see who and who doesn't benefit. This is deficient mismatch repair, huge benefit, big separation in the curves, just as we would expect. This is another molecular subtype, the P53 mutated group. These tend to be more aggressive, include the serous carcinomas, which many of you have heard of. It also looked like in this group there was benefit to adding the dostarlimab, which is thought-provoking. These patients seem to benefit. In contrast, if you look up here in the left upper corner, these are the rarest subtype of endometrial cancers, the polymutated. They have an excellent prognosis and they do very well in general. And as you can see, the survival is 100% in both groups, for both with or without the immunotherapy. So did they need it? Probably not. They all did well. And then lastly, down in the right-hand corner, you have another subset, which is the most common subset of endometrial cancers, which is called no specific molecular profile, which is probably we had lack of a better name there. But they have sort of varying profiles. And this is an instance where the curves you can see here truly come together. So the addition of dostarlimab in this specific molecular subgroup really didn't seem to benefit. Because this kind of looks like a banana, you're going to have to bear with me for a sec in that it's closed at the top and closed at the bottom. We call this the banana sign, and you don't want the banana sign because that means that you've got two curves that are overlapping. And so the benefit, there's not a big difference between the treatment intervention or not. So we don't want bananas. And in this group, neither of these two groups seem to benefit by the addition of dostarlimab, but the other groups did. And then this is just the overall survival. The previous slide was progression-free, and this is overall survival, but similar effects. So the two groups that seemed to benefit were the deficient mismatch repair, absolutely, and potentially the P53 mutated. The issue with this group is that they didn't power the study. This was not one of their original analytic endpoints. They did want to look at the DMMR patients specifically, and so they designed the study to pull them out. They did not design the study to look at these patients specifically, but we did get a positive effect. So it's hypothesis generating, but we can't really draw any firm conclusions from that. And then this, very quickly, we're going to go through these slides. So GY018 was a very similar study to the Ruby trial. It was a very similar population, and they added an immunotherapy to the carbotaxol backbone, but instead of dostarlimab, they added Keytruda, pembrolizumab, which is probably more commonly known, and the results were very similar. So they also showed improvement amongst both the proficient mismatch repair and the deficient mismatch repair groups, but with the biggest magnitude of difference in the deficient mismatch repair groups. Here they, in 018, showed these were the objective response rates, and so I liked this graph and wanted to show it. But basically, you can see here, again, objective response. These are the partial responders and the complete responders. So you can see that here, CRPR, CRPR. The red group is that group with the Keytruda, with the immunotherapy, the pembrolizumab, and the blue group is the control group, just the carbotaxol. And as you can see, you had 71% of patients had an objective response rate, which is really quite good, compared to 58 in the control. And if you notice here, for the complete responders, they almost doubled. So they argue that the addition of the Keytruda was beneficial. And these were the proficient mismatch repair patients. So these were the ones that you wouldn't have expected to see as big of a magnitude of benefit. And then again, the duration of response was 3 months, which is not as high as what we see with the deficient mismatch repair, but was statistically significant. So anyway, based on these two trials that I've talked about, the standard of care, this is the National Comprehensive Cancer Network that basically delineates what our standards are for all our different cancer types. And those two clinical trials landed the combination of chemotherapy plus immunotherapy as the preferred regimen for primary, advanced, and recurrent endometrial cancers. So very exciting. And so most of this is incorporated into our standard of care now. Now, this is the last of my endometrial cancer slides, and this is super busy. And this came from an even more recent clinical trial. And I feel like I needed to add it because it gives a little bit more of the story. So So the issue with the Ruby trial in 018 is that they really looked at an advanced patient population. So these were patients that had either been treated and the cancer had come back, or these were patients who had disease in the beginning that was enough such that even after surgery, you could still see it visible on CT scans. So these were people with more advanced disease. But the truth of the matter is that most of our endometrial cancer patients are patients that have surgery and then are usually cancer-free, although many of them are still going to require chemotherapy. And those patients were not studied on either Ruby or 018. So there's this big question hanging in the balance. Well, we know that giving immunotherapy is better for the patients that have advanced disease, for the patients who have recurrent disease, but what about the majority of the patients that we treat, those that have had surgery and then are going to chemo? So B21, which was a predominantly European-based study, which was just recently presented in fall of 2024 in Europe at a big conference there, looked at this population. So these were newly diagnosed endometrial cancer. And again, just like the other study, all the information on the patients in the study are over on the left. They were at high risk of recurrence, meaning they either had a P53 mutated or serous cancer that was early stage that we could chemo for, or they were stage 3, meaning they had lymph node involvement. So these are all patients that the standard of care usually is comprised of chemotherapy. And they essentially were divided into two groups. And here are the treatment groups. The bottom, the yellow, was basically carbotaxol, standard of care chemotherapy. There was, the investigators could decide to use radiation if they wanted. That was up to the treating physician. And then the experimental arm was carboplatin paclitaxel with Keytruda, with pembrolizumab given with chemo, and then as maintenance therapy afterwards. And so this was a study that was designed to evaluate what had already been evaluated in a more advanced population. And so interestingly, they did look at the different molecular subtypes, because that's something we now know. These deficient mismatch repair patients are the ones that probably benefit the most. This tiny plot over here on the right corner is something called a forest plot. And essentially what this is showing is that here are all the different groups over here on the left that they looked at. This one down the middle is the line over, like on the right side, the carbotaxol by itself is better. On the left side, carbotaxol with the pembrolizumab is better. The idea is that it's going to show you where all of these groups fall. And if you look at it, the only group that landed over here in the Keytruda plus chemo being better group was the deficient mismatch repair. So in this analysis, in this study, it really looked like the only group that benefited were the patients that had the deficient mismatch repair, that specific group. And if you look at this, which is the progression-free survival curve, these curves, and this included everybody, so this was the group, the entire group together, there was no difference. So it didn't seem to make a difference whether you gave the Keytruda or not. And so the takeaway from this trial is that for an earlier population, you probably you don't need the addition of the Keytruda only in the patients that are deficient mismatch repair. So the verdict is still out for some of these. I put a banana there. The lines are exactly together, so it's not very banana-like, but the concept is the same. So with the answer being, does everyone benefit? Probably not, but a lot of people do. So still a big breakthrough, but in the earlier stage, lower risk setting, not as important probably as in the more advanced setting. Okay, so we're going to go through cervix pretty quickly. The story is essentially the same as with endometrial cancer, meaning that we took standard therapy and we added immunotherapy to it because we thought, hey, perhaps this would be beneficial for these patients as well. And so this was a big international study, Keynote A18. This looked at newly diagnosed, cervix cancers that the standard of care would be treatment with radiation and chemo. So these patients did not have surgery. They were primarily treated with radiation and chemo. They had not been treated before. And they were randomized to two different groups. One was just standard cisplatin chemotherapy with radiation. And then the second group included the addition of Keytruda. So these patients got cisplatin with radiation and Keytruda with the radiation and the cisplatin, and then they continued Keytruda in a maintenance therapy after. And similarly to the other studies that we looked at in endometrial cancer, these are good survival curves. So this was the progression-free survival. The teal group here represents the group that got the Keytruda, and their progression-free survival was better. So it does look like the addition of the Keytruda helped. And so these patients had fewer recurrences. And then overall survival, this was not mature because many of the patients were still being treated, so we don't have final survival data, but it does indeed look like there was an improvement in the group that got Keytruda. So similar to what we saw in endometrial cancer, although the curves aren't quite as impressive, it looked like adding immunotherapy to primary cervical cancer treatment was also beneficial for the patient. So, and then this is a similar but different trial. These were advanced, and this is a little bit older, but also really dramatically changed the standard of care for cervix cancer patients. So these were advanced, either had persistent disease after they'd completed their primary chemotherapy with radiation, or they were metastatic disease at diagnosis. So they were not people that were candidates for radiation, and they were randomized. There were two different groups. So this is the eligibility. And then they were randomized. I can't remember where I put my pop-up. Sorry. They were randomized to either getting carbotaxol and Avastin plus or minus, which is the standard for cervical cancer, versus carbotaxol, Avastin, and Keytruda. And so this is why I call this the kitchen sink, because we're literally giving people 4 drugs. But when you look at the survival curves, again, the teal is going to include the patients that got the Keytruda. They both progression-free and overall survival were dramatically different. And in fact, for the overall survival, the final curves, there was an improvement of over a year in the patients that got the Keytruda with their chemo, and the curves have remained separated. So really, we look at this group and are seeing people that we think are cured in a group that we didn't previously think would be curable. So this was absolutely groundbreaking when it was presented. And it's, there are a lot of drugs, but they work well in conjunction, and this has become a new standard of care for us for cervix cancer. This is a similar study, beat cervix cancer. The difference is it was performed in Europe, but it was a very similar schema. They excluded patients with bladder and rectal involvement of their cancers, which has some implications for their treatment, but not much. And they gave carbotaxol, Avastin. These patients all gave Avastin. That was the standard. And then in the experimental group, they added atezolizumab. So it was carbotaxol, Avastin, atezolizumab. Atezolizumab is another checkpoint inhibitor similar to Keytruda, to pembrolizumab. And again, really similar outcomes, improved progression-free and overall survival. And for the overall survival, 10 plus months of improvement. So both of these studies have really changed the dynamic of treatment for cervix cancer. So we are also adding in immunotherapy for many of our treatment regimens. Okay, for cervix cancer. So now we're going to shift gears a little bit and talk about ovarian cancer. And many of you know this, but we just haven't seen the breakthroughs with immunotherapy in ovarian cancer that we've seen with our other cancers. It doesn't mean that we're not using them or we're not trying to use them, but we haven't seen the promise in ovarian, and probably because it's a different disease. So this is a nice slide that I borrowed from one of my partners, Elena Moore, and a very good friend of mine, that looks at the natural history of ovarian cancer. And most people are going to get chemo and surgery, or a combination in the beginning. And the chemo that is given after surgery is what we refer to as frontline chemo, meaning this is the first chemo that you get. This is after diagnosis, initial diagnosis. Some patients then go on to get maintenance therapy after frontline chemotherapy, and then if there's evidence of the cancer recurring or progressing, they would move on to second and later line treatments. So most of us are familiar with PARP inhibitors. In May of 2020, there were actually 9 FDA approvals for the use of these drugs in ovarian cancer. We use them as monotherapy, as treatment in the setting of recurrent ovarian cancer. We use them as maintenance therapies after chemotherapy in both the primary and the recurrent setting. So there was a period in time in which everybody was getting a PARP inhibitor after their chemo. And in 2022, many of these indications were withdrawn, and so the landscape has really changed. So I did want to take a minute and review this data. In order to review the data, these are some quick maybe reminders, maybe new information about how PARP inhibitors work. PARP inhibitors were essentially one of the very first truly targeted therapies that we used in gynecologic cancers, and these were in ovarian cancer. So there are different pathways whereby cells repair DNA damage, and that's how they survive. There's single-strand repair and double-strand repair, and there are certain people that are, at baseline unable to repair double-stranded breaks. For example, people that have BRCA mutations, you can see that listed here. These are patients at baseline that have a problem in this pathway from the get-go. And then there are other people that can over time acquire problems in this pathway. And these pathways are important because PARP is a protein that's actually involved in repairing DNA damage, specifically single-strand breaks. And so what that means is that this is a DNA molecule. It's a double helix. So there are 2 strands. If you end up with a damage to one of the strands, a strand break, which is supposed to be denoted by this lightning bolt here, then PARP protein is what helps repair it. And so if the PARP protein repairs the single-strand break, then you've got 2 double strands that are functioning well, and cell survival. The DNA has been salvaged. if you have a situation in which you have a single strand break and then you can't repair it, let's say that your PARP protein is not working, or you have somebody that's taking a PARP inhibitor that's actually impairing the ability of this PARP protein to work, you end up with a single strand break that's not repaired. Well, what happens in that case? Well, that can lead to double strand break. So you have one strand that's broken, that strand is flapping in the breeze, it doesn't get fixed, the other strand ends up getting broken. Now, this is not a big deal if you have functioning double strand DNA repair, right? So you've got a double strand break, but that's not a big deal because you've got fully functioning homologous recombination, which is the most important pathway in double strand break repair. However, if you have a patient, for example, who has a defect or a mutation in one of the BRCA genes, one or two, those patients out of the gate, they can't repair double strand breaks. They don't have that capability. So if you give them a PARP inhibitor, then for those patients, you're going to get more damage because you're setting them up to have you set them up to not repair a single strand break, which means the cancer cells end up with double strand breaks, and then you've got a system that is unable to repair double strand breaks. So that's why this is a good targeted therapy for people that have an inability to function via homologous recombination. And so there is something that we test for that many of you are aware of called homologous recombination deficiency, which is a mouthful, but basically that means if you have homologous recombination deficiency, you cannot adequately repair double strand breaks, which means you would be potentially a good person to give a PARP inhibitor to, because it means, I'm saying you, but I'm meaning the cancer. It means your cancer would be a good cancer to get a PARP inhibitor, because that means that if you create double strand breaks, you've got a tumor that can't fix them. So the idea is that you're going to get more tumor cell kill. So anyway, so now we're going to jump forward and talk a little bit more about PARPs in the frontline maintenance setting, which is the only setting right now in which they're approved. So without maintenance, these are numbers from old clinical trials, from the placebo groups of clinical trials, that some of which we'll talk about. So if you don't give maintenance therapy after upfront chemo in ovarian cancer, the progression-free survival it could be better, right? So looking at these trials that included advanced stage patients who got no maintenance, these are the placebo groups, the median progression-free survival was anywhere from 8 to 14 months, right? So the idea is, can we give something and make this better? And so there are 3 PARP inhibitor combinations that are currently approved for use after first chemotherapy in ovarian cancer. So olaparib or Lynparza is approved for use in patients who either have a cancer that has a BRCA mutation, or they themselves have a BRCA mutation that they inherited that's in the germline. And this was the SOLO-1 study. So this study showed big improvement when these patients were treated with olaparib or Lynparza after chemo. The next study looked at a combination. These were patients who had received bevacizumab or Avastin with chemotherapy, and then after chemotherapy, they continued their Avastin as maintenance. It's an IV drug, and then Lynparza, the PARP inhibitor, was added, and this showed benefit in the homologous recombination deficient patients. So in the BRCA mutated and the homologous recombination deficient patients, this combination of Lynparza and Avastin is approved. And so this was the PAOLA study. And then the last study that looked at using a PARP inhibitor as a maintenance strategy in primary ovarian cancer was the PRIMA study. And this study looked at everybody. So these were patients that had BRCA mutations, didn't have BRCA mutations, had homologous recombination deficiency, did not have homologous recombination deficiency. Anybody could participate, and they were treated with the PARP inhibitors, Zejula or niraparib. Okay, so all of these 3 drugs are still approved to use in the primary setting. So here are the data that come from these trials. So this is SOLO-1. So this was an amazing study. And you can see here, this is after 7 years of follow-up, and this is the overall survival, and clearly these curves are still separated. The interesting thing about this study is that the median overall survival at 7 years is still not reached in the olaparib arm. So it tells us that this is a drug that for this patient population, for many, is actually curing the cancer. So this is still widely used as the standard of care after chemo. for BRCA mutated ovarian cancer. This is the Paula study. This is a little bit more complicated of a slide. It was a little bit more complicated of a study. And so all of these patients got Avastin, which is the bevacizumab, the BEV here. So really, we're just looking at what happens when you add the olaparib or the Lynparza. But again, if you look at these curves have different patient populations. So this is the these are the BRCA mutated patients, and they clearly benefited by adding the Lynparza, which is what you would expect with an improved overall survival. So the difference in these curves. And then this curve, interestingly, included the homologous recombination deficient patients. So these were also patients that out of the gate, their tumors could not repair double-stranded breaks well through the homologous recombination pathway because it wasn't functional. But interestingly, they didn't have BRCA mutations. So that wasn't why they had this deficiency, but there's testing that we can do that determines who may else have this deficiency. And these patients, it also looks like they benefited from the Lynparza. The interesting thing is that the statistics didn't quite meet significance here, which is why I put a question mark. The curves look pretty good, but statistically, technically, these results were not significant. But that's probably because the data are immature. So with time, as we have more events, there's longer follow-up. I suspect that we'll see significance here. And then in the homologous recombination deficient, like the homologous recombination proficient group, the ones that didn't have any issues repairing double-stranded DNA breaks with their tumors, adding the olaparib didn't help. So you didn't see any benefit, which is what you would expect if you think, hey, this is a targeted therapy and it's going to work better for one group than the other. So this is why for this combination, it's only approved for use for the BRCA mutated tumors and for the homologous recombination deficient tumors, because those were the two groups that it looked like there was benefit in. So the PRIMA overall survival data came out fall of 2024 and was pretty disappointing in that we didn't see overall survival improvements in anybody in any of the groups, including the homologous recombination deficient group. And there have been a lot of challenges and questions as to why this was the case. And there are a lot of different speculations. This drug is still available to be used in everyone, and the progression-free survival benefit was good, and that does give people time off chemotherapy, so it's still in use. But at least based on this trial, it didn't look like we didn't really see overall survival improvement with the addition of the drug in any of the groups. But again, I don't want to totally throw, we're not throwing the PRIMA study out with the bathwater, because like I said, even though we didn't see an overall survival benefit, there is a significant progression-free survival benefit, and that's definitely still valuable. So these were the control groups in these trials compared to those that got the intervention. We didn't talk about bevacizumab by itself. Compared to nothing, but it added a bit of progression-free survival. This here, the SOLO-1 study, so progression-free survival with nothing, with placebo was 14 months, and then with olaparib was 24 months, so a big difference. And then Zejula, this is really impressive with the niraparib. Control group did not get the drug. Median progression-free survival was 8 months. With the niraparib, this was the entire population, so it included those that had BRCA mutations and were HRD deficient, was 36 months, so really big improvement. And then with Paula, when they added the olaparib to the bevacizumab, they got 24 months versus 15. So again, still benefit to these drugs, although perhaps not as much as we were hoping for when we started the journey, 5 years ago. And so for maintenance in the recurrent setting, we've lost a lot of the indications for treatment. So right now, for second and later line chemotherapy, you have the option to use a PARP inhibitor only really in the BRCA mutated tumors. So that this is not as widely used in the recurrent setting, and most patients are getting it up front anyway. So there are fewer patients that most patients have been exposed. Okay, so what about immunotherapy and ovarian cancer? So I put this up here. It kind of gives me a headache. There's a lot going on. It's probably going to give you guys a headache. And I'll go through it pretty quickly. This is a really complicated study. In my personal opinion, I don't think it was well done, and it was probably a lot of money spent for not an answer to any question. But what they did is they took this is similar to Paula, essentially, which was the Avastin and the Lynparza combined. So they took newly diagnosed stage 3 and 4 ovarian cancer patients that had not received, these had not received any prior chemo. This was up front. And they excluded patients that had BRCA mutations because there was a placebo arm that didn't get Lynparza. And so they didn't include those patients in this study, so that's the only difference. But basically, if you look up here, they have 3 different arms. These are really complicated. If you looked up here to arm 1, this was the standard of care therapy arm. So this was essentially chemotherapy with Avastin and then followed by Avastin maintenance. But because they also had an immunotherapy add-on, and they also had a PARP inhibitor, the Lynparza add-on, there were a bunch of placebos. So for example, for arm 1, you had an immunotherapy placebo that was given with chemotherapy. And then in the maintenance phase, you just had Avastin. So you had an immunotherapy placebo and the Lynparza placebo. In arm 2, this was chemotherapy with Avastin with durvalumab, which is a checkpoint inhibitor immunotherapy. And then for the maintenance phase, they got Avastin and they got the immunotherapy, and they did not get olaparib, they got a placebo. And then for arm 3, they got everything. So they got chemotherapy, Avastin, immunotherapy, and then for maintenance, they got Avastin, immunotherapy, and Lynparza and olaparib. And when you look at the survival, it looks like the group that got everything did better. And they designed this trial really to look at arm 1 versus arm 3. Arm 2 is experimental. So you were comparing the group that only got chemo and Avastin to the group that got everything, and they did better. But the question that is unanswered is what contributed to this. So the arm 3, they got immunotherapy and they got Lynparza. Well, we know from the other studies that we just looked at that we saw progression-free survival improvement when we added PARP inhibitors after chemotherapy. So how do we know that the immunotherapy did anything? Did it do anything, or was this just driven by the Lynparza? And I think most of us feel like probably the benefit that we're seeing in the group that got all the stuff is probably just from Lynparza alone. Like, we have no indication that the immunotherapy contributes at all. So it was a confusing trial, and I'm not sure what answers we got from that, but it didn't look like the immunotherapy made a big difference. This is another trial, which is a little bit less confusing, also looked at the combination of immunotherapy with a PARP inhibitor. This was Zejula or niraparib that was used, and atezolizumab was the immunotherapy. The difference is the ANITA trial, these were recurrent patients. So these were patients who could have had up to 2 chemotherapies before. They had chemotherapy again, carboplatin with something else, and then they were followed by either immunotherapy and Zejula or just Zejula by itself. And in the group that got immunotherapy, they also got immunotherapy with the chemo, similar to the other trials. And essentially, when they combined the group that got the immunotherapy, the group that didn't, there was absolutely no difference. So the curve completely overlapped. So it does not look like in this study, which was a little bit of a better study because the groups were very similar, except one got immunotherapy and one didn't. It really just looks like it didn't make a difference. So there's your banana. So this is the banana curve. So this was not, these outcomes were pretty disappointing. Now, does that mean that there aren't good options for ovarian and other cancers that are coming down the pipeline? No, no, no. There are lots of targeted therapies that are under development. I'm going to fly through these so we can get to the trials that we have open here, but we can always come back to these. So antibody drug conjugates, you will hear us talking about these all the time. These are super exciting, and there are a bunch that are on the market now. So similar to the dostarlimab, the backbone of these is a monoclonal antibody. But what they do in the lab is they actually link heavy chemo doses to these antibodies. So what happens is you give people these drugs, the antibodies actually are targeted towards receptors or proteins on the cancer cell membrane. So these are cancer cell specific. The antibodies take the drugs to the cancer cells, and then they dump these high doses of chemo right on the cancer cells themselves. And so what we're seeing is just highly effective chemotherapy with less toxicity because we're able to deliver a much bigger dose to a much more selective population. So the biggest one that's been on the market and has been in the press a lot over the past couple of years is called Enhertu, and it targets HER2, which is another cell surface marker. And we've just seen incredible results in endometrial, ovarian, and cervical cancer. These are patients, so this was the PanDestiny trial, which looked at many different cancer types. All of these patients had been pre-treated, had had many lines of chemo. A third of them had more than 3 lines of chemo, and we're seeing objective response rates 80%, 60%. So really, we're seeing results that we haven't seen in this patient population. And so what's happening, and I'll talk about it a little bit at the end, is we're trying to push this drug into an earlier setting where we think that it'll be even more potent and hopefully could lead to some cures in some of these patients. So really exciting. We're excited about Enhertu, and you'll hear about it all over. This is Elahere or mirvetuximab, which is used for use in ovarian cancer and targets the FOLR1 receptor. So it's another antibody drug conjugate. Similar, the target is a receptor that's found largely in ovarian cancer cells and not in other parts of the body. But essentially, this was also a very promising drug that is tolerated very well and has shown efficacy in ovarian cancer and is one we use frequently. But it's definitely another good targeted therapy that's improved treatment for our patients. And then, we're getting to the finish line. I just want to take a few minutes to go over some things we have open at Endeavor. And so these are things that if they're of interest or you think you might qualify or you know somebody that might, certainly be in touch with us. These are not just for our patients, these are open to anybody. So we're going to start with uterine cancer. Most of the trials I have right now that are open are for endometrial cancer because there's just been a lot of breakthroughs in general. And a lot of good things out there. So this is a frontline trial plus maintenance, which is what we want really for everybody, is to have a good treatment regimen and then maintenance to follow. So these are P53 mutated or the CERAS, the high-risk endometrial cancers, and we're looking at just the regular chemo backbone compared to chemo plus Herceptin, with chemo and then as maintenance, and then a Herceptin and a dual anti-HER2 combination, again, as treatment and maintenance. And so these are also anti-HER2 drugs, but not Enhertu, different drugs. And so this is enrolling right now, and it's all stages, but newly diagnosed uterine serous or P53 mutated endometrial cancers. So this is one that we're excited about. This is a super exciting one. So this is also frontline and recurrent endometrial cancer as a maintenance option. The design is very similar to what we saw with Ruby and GY018, except it's looking at a different drug. So these are not the DMMR. DMMR patients are allowed on this, but this is specifically looking at TP53 wild type patients. So the P53 mutated patients, who are the ones that we're looking at in this trial, are not eligible for this trial. These are patients who don't have, we don't see as good of responses, with immunotherapy. This was that group kind of at the bottom right corner that looked like maybe they didn't really benefit from the immunotherapy. And there's an oral agent called selinexor that works very well as maintenance for the P53 wild type patients. And so this is a study that after chemo you enroll, and then you are either taking the drug or placebo, because otherwise the standard of care for these patients is actually no maintenance typically. And the early studies show amazing curves, just like what we're seeing in the deficient mismatch repair group with the use of immunotherapy. So we're really excited about this trial, and it's open and enrolling now. This is another endometrial cancer trial looking at an antibody drug conjugate, an ADC. You can see it here. Here's your monoclonal antibody, and it's linked. It has a heavy high-dose chemo that's linked to it, and the idea is it targets this protein on the cell surface, TROP2, and can deliver heavy-duty chemo doses to the cancer cells. This is a randomized controlled trial, so you don't necessarily get the experimental group and the standard of care group. They're two common chemotherapies that we use that are effective. So this is open. This is probably not going to be open for too much longer. It's been enrolling really well, but is a well-tolerated drug and looks like it's effective. So this is another thing we have open. For leiomyosarcoma, for early stage patients, we typically don't treat them with anything. So they have surgery and then they go on to observation. But this is an interesting study that is looking at estrogen receptor positive cancers and whether if we add an estrogen blocker, it might be helpful. So this is a very straightforward study. After surgery, patients are randomized to either do letrozole, which is a pill, which is taken by a lot of breast cancer patients and some of our gynecologic cancer patients, or observation. So it's a nice kind of easy option for something that may be beneficial for this is for sarcoma, for leiomyosarcoma, and this is a very complicated schema of this is also a targeted trial for patients with both endometrial and ovarian cancer, and this is based on molecular profiling. So most patients, we are going to check the molecular profile of their cancer to try to figure out, can we use some of these targets, like in HER2, for example, or FOLR1 for mirvetuximab, Elahere, if you have the FOLR1 receptor. So as part of that testing, you get information on other genes that may be abnormal, and depending on what they are, we can target them. And so this is a big national trial combo match. None of these arms don't have immunotherapy, but some of them do. And the idea is if you match, if you have one of these molecular targets, then we can put you on one of these groups and use these targeted agents. And so there are several arms on this trial, and we're enrolling on them. So very exciting. And then for ovary, there's a fasting trial. That's my trial, actually, where we're looking at treating people with carbotaxol, either primary or recurrent, and we're adding a fasting mimicking diet to it to see whether we get better symptom management with chemo in patients that fast before chemo and whether we get a better tumor response. So that's open and it's been interesting so far. And then this is super exciting for low-grade serous. So this is a rare type of ovarian cancer, but for low-grade serous carcinoma, there's an oral regimen, a combination regimen of vudametinib plus defactinib, which has had very good results in early phase clinical trials. And so this is a bigger trial, and we're testing it against the standard of care. So this is open and also is enrolling really well. So, and it's a very well-tolerated combination that looks like it works well. And I think that might be it. Oh, yeah. Well, so this is kind of the most important slide, is that if you're interested in information about any of these trials, Michelle Brito is our research coordinator. She's kind of the head of our clinical trials from a nursing standpoint and gets emails from people about participating. And any of us would be happy to see you or to talk to you about any of these opportunities. And I do have 2 Destiny trials. We have 2 big HER2 trials that are opening, one for ovary, one for endometrial, probably within the next 4 to 5 months for patients that are HER2 positive. So there's always stuff coming down the pipeline. So if you're looking for something or you're curious to see what we have, we'd be happy to talk. And I think that's it.